department chair, who will share a few words of welcome, and then Dr. Bronlin will introduce our guests.
Good morning, everyone, and thanks for attending Grand Rounds. Special thanks to Dr. Safa and Forbes from Detroit for joining us this morning with another very timely topic. Departmental announcements are not too many. We're seeing a great uptick in people returning to the labs this week. So the basic sciences are moving along again. Clinical research is picking up as well this week. So those are all very good positives. I just want to remind people that tomorrow afternoon at 4:30 we have a faculty meeting. So that will obviously be in Zoom, and please try and attend. So with that, I'm going to turn this over to Dr. Bronlin to introduce our speakers. Liz?
Thank you, Dr. Naglia. It's a real pleasure to have our colleagues from Detroit give us this timely Grand Rounds today. We have one rising star and two supernovas who will be presenting. Raya Safa is a cardiac intensivist at Detroit Children's Hospital, who trained in pediatric cardiology at Detroit Children's and then did a fellowship in cardiac intensive care at Northwestern University. She's been on the faculty in Detroit since 2017, and in that time she's written 8 papers and a book chapter, so totally a rising star. Dr. Forbes is a supernova who is a professor, the Carmen and Ann Adams Professor in the Department of Pediatrics at Detroit Children's Hospital and Wayne State Medical School. He did his fellowship in pediatric cardiology at Baylor and an interventional cardiology fellowship at Northwestern. He's the director of the cardiac cath lab. He's on the editorial board of several prominent journals, and he's a reviewer for the New England Journal, the Journal of American College of Cardiology, and the American Heart Journal. He is the PI on 10 active national or international grants, the co-I on 5 more. He's got more than 70 published papers, 5 review articles, 169 invited presentations. He's mentored or proctored hundreds of physicians in device and stent placement for the cardiac catheterization lab. And finally, our own third person who will be giving Grand Rounds today is Marie Steiner, our own personal supernova, who's a professor of pediatrics and critical care medicine, hematology, and oncology. She's fully Minnesota trained and is the NIH chair on a red cell study section. She has an NHLBI clinical trial on red cell storage. She's the author of more than 90 papers, multiple invited talks. We know her for her focus on clotting and bleeding. She's the go-to person for postoperative bleeding, for LVAD advice, and for transplant. So with that, folks, please sit back and enjoy this wonderful presentation.
Good morning. Thank you for the opportunity to present today. We're going to talk about COVID-19 associated Kawasaki-like disease and Pediatric Multisystem Inflammatory syndrome.
Hopefully we will.
Hopefully.
My light's not switching.
In the lower, there you go.
Okay, so we're going to start with an introduction. We're going to talk about the criteria that define Royal College and CDC. And we're going to talk briefly about the presentation in Detroit and more specifically about 2 of our recent cases in ICU who required ECMO. We'll talk about the clinical course, imaging, biomarkers, treatments, and we'll end by a summary. So fortunately, as we know, most children with COVID-19 have been asymptomatic or have minimal disease with no respiratory distress as reported in recent Chinese and American cohorts. And the incidence remains rare, as shown by a recent review by the Chinese Center paper after reviewing almost 70,314 cases. And that showed that the rate of infection is less than 1% and in children younger than 10 years of age. And most of these children had really minimal symptoms and did not have any significant morbidity. Similar findings was also reported at the recent American cohort by CDC that reviewed almost 150,000 US cases, and 1.7% occurred in patients less than 18 years of age, and similarly they had minimal symptoms with no significant morbidity. So on April 27, 2020, the Royal College of Pediatric and Child Health announced an alarm stating that children can be affected with pediatric multisystem inflammatory syndrome that's associated with COVID-19 and that can have significant morbidity and mortality. And they published a document and defined the criteria that determine the case definition. Any child with persistent fever with associated inflammation and have evidence of single or multi-organ dysfunction met the criteria, and that also include having full or partial criteria for Kawasaki disease. Other microbial causes need to be excluded, including bacterial sepsis, staphylococcal or streptococcal shock syndrome, or infections associated with the typical myocarditis viruses, such as enterovirus. And SARS PCR testing may be positive or negative in these patients. Similarly, last week, CDC also on May 14, 2020, they provided background information on several cases of a recently reported multisystem inflammatory syndrome in children associated with coronavirus disease, with COVID-19. Their criteria included any individual aged less than 21 years of age presenting with fever, have evidence of inflammation, and any evidence of clinically severe illness requiring hospitalization with multi-system organ involvement at least 2 and above. With no alternative diagnosis and positive for any current or recent SARS infection proved by PCR, serology, or antigen testing, or COVID-19 exposure within the 4 weeks prior to the onset of symptoms. Any patient who had a fever more than 38 for just more than 24 hours, or report of subject fever lasting more than 24 hours met the criteria, and also the lab marker will include, but not limited to the mentioned biomarkers, including severely elevated CRP, ESR, fibrinogen, procalcitonin, D-dimer, ferritin, LDH, interleukin-6, elevated neutrophil lymphopenia, and low albumin. Also, these individuals may fulfill partial or full criteria of Kawasaki disease, and they need to be reported. And any pediatric death with evidence SARS infection, the multi-inflammatory syndrome in children should be considered. So since the alarm that was announced by London on April 24, there have been several webinars describing the different type of clinical presentation in Europe and here in the US, especially at East Coast. And there are 3 big clinical presentations that have been increased in incidence since the COVID-19 pandemic, and the typical incomplete or atypical Kawasaki disease with coronary artery involvement or not, and that occurred in children through adolescence, and they can have myocardial dysfunction. The second big categories are patients can present with refractory vasodilatory shock, similar toxic shock syndrome, and they will have normal heart function, and that have been more described at New York and also in Europe. And the last category is the abnormal heart function with cardiogenic shock. And interestingly, we're seeing these patients more frequently here in Detroit, and we'll talk more about it in details. And you can have also cases that have been reported combining all the above findings. Italy, the epicenter of the pandemic COVID-19 in Europe, also recently published their experience, and in the past month, just last week, and they found a 30-fold increased incidence of Kawasaki-like disease, and they described it as having features of macrophage activating syndrome and had high rate of cardiac involvement, and they also concluded that similar outbreak of Kawasaki-like disease should be expected in other countries involved in the COVID-19 epidemic. So what about our experience in Detroit for now? The two major clinical presentations that we've been seeing since the end of March till now, divided in two clinical categories. We've noticed that patients are presenting with typical incomplete or typical Kawasaki disease with coronary artery involvement or not. They're not in shock, and these patients are typically being admitted to the floor. Since early April, we've been seeing more patients presenting in shock, and they meet the criteria defined by the Royal College and recently by the CDC. And interestingly, most of them have abnormal heart function with cardiogenic shock, and it's associated with severe inflammation, and they require ICU admission. So the since end of March till now, we have 32 suspected confirmed patients. Most of them have African American ethnicity. We had 2 patients who had Arabic ethnicity and 1 Caucasian. The age ranged between 8 months to 17 years old. Most of them were previously healthy. A few of them had mild persistent asthma or were morbidly obese. There is male preponderance, 60% of the patients were male. And there was history of COVID-19 exposure. Early on, unfortunately, the testing was limited, and we just recently started to do antibody testing, and we've been doing now for all the patients, especially for the one who have negative PCR, and we're planning to do these antibody testing when we see them in the clinic as outpatients. 1/3 of the patients, 30%, required intubation. And to mention, it's important to mention that these patients did not require intubation for ARDS picture. They required intubation because of cardiogenic shock with associated pulmonary congestion and pulmonary edema. 2/3 of the patients required inotropic support. Patients were severely critically ill and required with AA. And fortunately, we didn't have any deaths. I'm gonna talk now more in details about the 2 cases that required VA ECMO. So the first one, it's about 60-year-old previously healthy African-American female who presented to the emergency department with 6 days history of high-grade fever, abdominal pain, swelling of the extremity, and had generalized maculopapular rash with no history of COVID-19 exposure. The physical examination was remarkable for tachycardia, gallop, conjunctival injection, tachypnea, hepatomegaly with delayed capillary refill and poor peripheral perfusion. This is the EKG when she presented to the emergency department, and it showed that she had sinus tachycardia. This is the echocardiogram on admission. As you can see, the patient had mild to moderately depressed function with fraction shortening at 24% and ejection fraction at 49.3%. The coronary artery system was normal and left main coronary 4, and left anterior descending Z-score was at 1.3. Interestingly, she had also a dilated IVC, as you can see here. The EKG also on admission in ICU showed now that she's developing accelerated junctional rhythm. And the admission labs were significant for mild anemia, mild leukocytosis, neutrophilia, pandemia, 15 lymphopenia, normal platelets, It was significant for the elevated troponin, 114. Usually the normal level is less than 17 in our center. She had mild acute kidney injury, normal liver function, mild hypoalbuminemia. She was severely hyponatremic at 118, and she had increased inflammatory markers, including LDH, fibrinogen, severely increased CRP. Interleukin 6 was 53. The normal value is less than 6. She has severely elevated D-dimer 4.21 and severely elevated ferritin at 699.5. The SARS PCR was done and it was positive, and other viral and bacterial testing was negative. Patient had worsening shock within the first 24 hours of admission, and she required escalation of inotropic pressor support due to hypotension. And due to the presentation with incomplete Kawasaki-like presentation, she was started on IVIG and aspirin. She persistently developed accelerated junctional rhythm with poor perfusion, and her condition worsened into hypoxia with seizure activity, and she had pulseless electrical cardiac arrest. CPR was started, and she was intubated, and she had return of spontaneous circulation after less than 5 minutes. The patient had recurrent episodes of ventricular tachycardia as shown here, and because of the worsening clinical condition and persistent arrhythmia, the decision was made to support her with mechanical support on VA ECMO. This table showed the closest value, lab values before ECMO, and you can see she had worse lymphopenia at 4%. Her troponin is severely elevated at 142. Platelets remains normal, and she had persistent elevated inflammatory markers, reactive, and hyponatremia has improved after correction with hypertonic saline. The ECMO course was unremarkable. We were able to anticoagulate appropriately with unfractionated heparin. The maximum dose needed was 24 units per kilogram per hour. Aspirin was discontinuous while she was on ECMO. Because of the history of seizures, we did EEG, there was no seizure activity. She was on Keppra. She was started with 2 doses of IV methylprednisolone. And because of her critical condition, use of IV remdesivir as a compassionate use was approved, and it was administered after parental consent. The inflammatory markers declined to near normals over the course of several days, and the inotropic support was weaned off within 24 hours of ECMO initiation, and the cardiac rhythm returned to sinus with intermittent junctional rhythm on day 3 of ECMO. And organ completely recovered. Tolerated a trial off on day 6, and we did an echo during the trial off, and as you can see here, the function was completely recovered and normal. And there is some mild hypertrophy, and we think it might be related to the edema, but the function is completely recovered with normal systolic function. She was successfully decannulated from ECMO on day 6, extubated to nasal cannula on day 8, and discharged home on day 14 on aspirin daily. And the serologic testing was done prior to IVIG administration, and it was also positive for IgG antibody to SARS-CoV-2. So this is a table just to summarize the trend of all the laboratory markers, and interestingly, the lymphopenia has markedly improved, and also the ferritin, all the inflammatory markers markedly improved. The troponin was markedly improved, as you can see here, from 114 to 37, and the CRP, other inflammatory markers, were also markedly improved from 450 to 33.6. Moving to our second case, previously healthy 17-year-old African-American presented to the emergency department with 3-day history of high-grade fever, abdominal pain, vomiting, rash, and also no history of COVID-19 exposure. Physical exam was remarkable for fever, tachycardia, tachypnea with normal blood pressure and good peripheral perfusion. Patient had conjunctival injection, cervical lymphadenopathy, and maculopapular rash on wrist and posterior thighs. The initial lab was remarkable for lymphopenia at 6%. Interestingly, the troponin admission was completely normal, 13. The normal level is below 17. D-dimer was elevated, ferritin was normal, mild acute kidney injury, albumin was completely normal. He had elevated fibrinogen at 170/73 and elevated CRP at 149, and he had mild hyponatremia. Also, the PCR was done and it was positive for SARS-CoV-19, and he was admitted to the ID service and treated with IVIG and aspirin as he presented with incomplete features of Kawasaki disease. And he was tested for viral and bacterial infection, and the testings were negative. This is his EKG on admission, and it shows sinus tachycardia. This is his echo on admission. As you can see here, the function is completely normal, normal systolic function with ejection fraction normal at 70.7. The coronary artery was moderately dilated with left main coronary artery measured at 6.4 and Z-score at 3.7, and there were no aneurysm. The left coronary artery was completely normal. The IVC, interestingly, also was dilated. 3 days after admission, he remained persistently febrile, and his clinical condition worsened into hypotension with dizziness. And we did repeat an echocardiogram. And this is on day 3. You can see that there is change compared to the one on admission, and now the function is mild to moderately depressed. There is also septal hypokinesia, and the ejection fraction is at 46.3. The coronary artery measured the left main at 7.1 and Z-score at 4.2. Also, he had new onset of tricuspid regurgitation with the right side pressure measured at 30 millimeter mercury that was mildly increased, and also he had mild mitral regurgitation. Interestingly, as you can see here, these pictures show that he had worse IVC dilation. And at that point, he was transferred to the ICU, and his EKG on admission to the ICU showed first-degree AV block with incomplete right bundle branch block. He remained hypotensive with increased cardiac markers of troponin and BNP, and he was started on IV epinephrine infusion. This is the EKG showing sinus tachycardia with prolonged PR consistent with first-degree heart block, and he had incomplete right branch block. On day 4, his clinical condition markedly worsened, and he developed refractory cardiogenic shock with accelerated ventricular arrhythmia, and he had seizures. He was intubated, and the repeat echo showed now severely depressed biventricular systolic function. And due to the cardiogenic shock and persistent arrhythmia, he was cannulated to VA ECMO via the right carotid artery and internal jugular veins. And this is his echo on day 4. And you can see the significant change of the function compared to the one on admission and compared to the day before. And the ejection fraction was at 27.9 and fraction shortening at 12.8. This EKG tracing showed the ventricular arrhythmia that he's having, and they were recurrent and persistent. You can see here the white complex tachycardia. And the labs just before lymphopenia at 4%, ferritin was markedly elevated. D-dimer was also markedly elevated at 11.85. The troponin on admission was completely normal, and on day 4, significantly elevated at 967. He had hypoalbuminemia. The other inflammatory markers, LDH, fibrinogen, C-reactive, was significantly elevated. And interleukin-6 also was markedly high at 286. Our normal value is less than 6. So because of his critical condition, he was given Infliximab 10 milligram per kilogram 1 dose, and he was given methylprednisolone 40 milligram Q8 for 3 days. And also IV remdesivir was approved for compassionate use and was administered after obtaining parental consent. Anticoagulation was smooth also, and it was established with unfractionated heparin, and the maximum dose was 29 units per kilogram per hour. And while he was on ECMO, he was off aspirin. And EEG also showed no seizure activity, and he was on Keppra. Inflammatory markers markedly declined, and his inotropes were weaned to low-dose epinephrine after 24 hours. He was hemodynamic in an ECMO weaning trial. And you can see here the function in day 4 after ECMO, and the function is completely recovered and it has normal biventricular systolic function. So he was successfully decannulated from ECMO on day 4. He was extubated to nasal cannula on day 7 of hospitalization, and he continues to do well from hemodynamic and neurologic standpoint. So this is 72 hours after decannulation, and you can see the function is recovered. He has normal biventricular systolic function. There is some septal hypokinesia. He remains hospitalized for sedative weaning and hypertension management, and serologic testing also was done prior to IVIG administration and was positive for IgG antibodies. This table also shows the trends of the laboratory markers, and you can see here the D-dimer markedly improved from 11.85 to 6.28, 72 hours after ECMO discontinuation. Ferritin also, after it peaks to 1212, it's downtrended. The high sensitivity troponin peaked at 967, was downtrending also, and now it's normalized. The inflammatory markers, the LDH, the fibrinogen also markedly improved and downtrended, and same thing for the CRP that peaked at 406, and 72 hours after ECMO decannulation, it went down to 23. This is his echo 2 weeks after admission. You can see the function is completely recovered, but you can see there still remains septal hypokinesia, and there is still mild hypertrophy, and we think it's consistent from the edema, and it will be very interesting to see in the next follow-up visit in the clinic what would be the cardiac findings. Same thing for the IVC, it's normal in size now. The coronary artery size also improved, and now Z-score is 1.7. And his EKG also was completely normal at 2 weeks. So our 2 most critical cases had high-grade fever, had gastrointestinal symptoms, had incomplete Kawasaki-like features. They had profound systemic inflammation and cardiogenic shock. Both of them were positive for the PCR and for antibodies, IgG, and they met the criteria of case definition defined of MISC or multisystem inflammatory syndrome in children by Royal College and CDC. Fortunately, they had good and quick response to treatment. So the biomarkers that can be helpful to differentiate between the 2 big category of presentation, between the shock presentation, MISC, is the elevated troponin compared to the Kawasaki disease-like presentation with no evidence of shock. The patients who present in shock have significantly higher troponin, have normal or low platelet, in opposite to patients with Kawasaki disease who have typically thrombocytosis. They will have mild hypoalbuminemia, and also, interestingly, they will have elevated interleukin-6 and ferritin compared to the Kawasaki disease-like presentation, which are normal. They will have lymphopenia that's severe, and also severely elevated D-dimers. And these biomarkers can be helpful to differentiate, besides clinically, between these 2 big categories. Interestingly, we have noticed in our population the cardiac manifestation is prominent, and we've seen severe cardiac inflammation with troponin leak, that manifests with depressed systolic, mainly the left ventricular function. We've seen patients who had dilated coronaries. Also, patients progressively develop mitral regurgitation and tricuspid regurgitation consistent with valvulitis. Patients also noticed to have dilated IVC and elevated right-sided pressure consistent with systemic venous hypertension, and also patient had developed pericardial effusion. And these findings might be secondary to the severe systemic inflammation that they are having, and that's causing some kind of myocardial stun. And fortunately, they're responding very quickly to the treatment in 48, 72 hours. So what about the treatment? We've been using treatment that's used for Kawasaki disease. And for the last 3 years, since the updated AHA guidelines published at Circulation, for first-line treatment for typical Kawasaki disease consists of IVIG, 2 grams per kilogram, and we've been using moderate dose of aspirin, 30 to 50 milligrams per kilogram per day, and transition to low dose once daily when febrile for 48, 72 hours. In patients who have refractory Kawasaki disease, the updated AHA guidelines mention that the possible second use of IVIG, Infliximab 1 dose, or pulse dose of IV steroids, cyclosporine can be an option, and also immunomodulatory monoclonal antibody therapy. In our center, we've been using Infliximab 1 dose as a second-line treatment for severe and refractory Kawasaki disease, and that has been our approach here for our patients now with the PIMS associated with COVID, to use IVIG first in the first 24 hours. And if the patient has persistent cardiac inflammation with persistent fever and systemic inflammation, we've been using Infliximab as a 1 dose as a second-line treatment. And several studies have shown in Kawasaki disease they have elevated tumor necrosis factor in acute phase, and it's associated with development of coronary artery. And Infliximab is monoclonal antibody against tumor necrosis factor in acute phase. And there was a retrospective review of patients with refractory Kawasaki disease treated with Infliximab, and they showed response to treatment with resolution of the symptoms. Our center is a part of KIDCARE trial, and it's Kawasaki disease comparative effectiveness trial, and it's led by Dr. James Byrne, she is a Kawasaki expert at San Diego, and they include 30 sites, and including our center, and it's a phase 3 randomized multi-center open label study that's still ongoing, and it will compare the effectiveness of second-line treatment between Infliximab and second IVIG infusion. So, and in our experience for this number of patients, this regimen has been working, and as we all know, we have so much to learn about this new disease. There are so many questions that need to be answered about the mechanism of the disease, and it sounds it's a severely abnormal immune response, and it's antibody-mediated delayed severe inflammation and organ injury. These patients have both IgG positive and they had positive PCR. Can it be related to direct viral injury? Why some children have more susceptibility compared to other children? Why some children, especially in our population, have more cardiac inflammation that needs to be addressed, and genome sequencing will be helpful. And why in certain areas, same here in Detroit, we have more cases. Is it related to strain viral mutations? We need to determine what really are the biomarkers that can be helpful to differentiate between the typical Kawasaki disease shock syndrome, and the new entities defined as MISC or multi-inflammatory syndrome in children. We have the treatment options. It's variable between all the centers, and collaboration and research are needed to answer these questions. Thank you.
Is there any questions?
There were quite a few that came in. The first one, there were a couple of questions about if either your institution or if you're aware of other institutions have done cardiac biopsy as a part of the diagnostic process?
No, we have not. We tried it in all these acute situations. It makes, I don't know if John's on the phone or Guru, but it makes me nervous to try to do any biopsy with ongoing inflammatory process. One of the things that is just my take on this is that these kids, the cardiac manifestations of shock come in really quite rapidly. She just mentioned the two that went on ECMO, but there's a few others that came very, very close to ECMO that did not, and we just kind of got through it. Wing and a prayer, but with those patients. But the other thing is just as quick as they go into it, they simply come back out of it. It's just really amazing of how quick they get hit and how quick they make their recovery from all of this. But we haven't considered doing any further testing on the heart aspect from this.
Tom, do you think that cardiac MRI in the future will be important for them?
That's a very good question, and we're considering not in the immediate period, maybe 6 months for those who had significant troponin leak and cardiac inflammation to perform the cardiac MRI. And we're planning to do it as an outpatient setting.
We have a question from one of our rheumatologists. If you've used tocilizumab, an IL-6 blocker, in any of your patients?
No, we haven't used it, which was also an option, and it's been used in adult population, especially these patients had significantly elevated interleukin-6, but we haven't used it. The only medication that we've used for now are IVIG, steroids, pulse dose, and the Infliximab.
It's a good question. It's an interesting thought.
I know we certainly had an extensive conversation with our group about the pace of disease progression with these patients, trying to understand how we might identify them in the outpatient setting before they get really sick. I was curious about that older patient that you presented who seemed like he had come within 3 days of fever and was on the floor for a few days. What was the sort of pace of his illness once he was in the hospital? Did it become clear quite quickly that he was getting sicker, or was it over a course of a couple of days?
So initially he was clinically doing well beside the fever. He did have adequate perfusion, his blood pressure was good. And by day 3, he started to show worse findings. He was dizzy and he had hypotension. And that's why we did the echo on day 3, and then the echo showed worse function. And rapidly after that, since after he was admitted to the ICU, within 24 hours, he markedly worsened and to severely depressed function, and he was placed on echo. So as outpatient, it's a very good question. How can we screen these patients? We've seen many patients in the ED now coming with history of fever and syndrome for inflammatory markers and troponin. And if the troponin is elevated, significantly elevated, they need to be addressed with further testing immediately in the ED, and they need to be admitted.
Great, thank you. And I know we've got a couple of other excellent speakers who have some materials to share, so maybe we'll move on to our other 2 speakers and then grab some more questions at the end.
Okay, my turn? My turn.
Yep.
Okay, hi. First of all, Raina, thank you for putting my slides in with yours, because I learned how to use an abacus, and so this is all very new for me. I'm Marie Steiner. I do pediatrics, hematology, critical care, and this is more or less of a speculative, gee, what do you guys think kind of conversation on whether or not there's actually hemostatic imbalance in this process that we're seeing. Raina, do you have control or do I have control to advance? I don't think I do. Thanks. Turns out that there's not much about hemostatic imbalance even mentioned in the different discordant definitions that have been coming out from prestigious organizations across the world. National Health Service only mentions an elevated CRP. A couple weeks later, the CDC and evidence of inflammation includes fibrinogen, D-dimer, ferritin in their definition. And then just the next day, the World Health Organization, if you pop up to clinical findings, says coagulopathy. And I guess I guess these are not going to work. That's okay. Keep going. Next one. They worked on mine. So why would we even think about the question in this disorder? Why would we even wonder if there's a hemostatic imbalance? Well, if this new entity is due to COVID-19, infection with this virus is an incredibly toxic endothelial insult because we don't have prior host immunity and we don't have clear therapies that halt its effects. And so there's a nice paper that it just came out this month in Journal Clinical Medicine by Sandhu, and I stole her diagram. The endothelial injury and death that we see, regardless of the cause, triggers and enhances the coagulation cascade, produces fibrin deposition in the microvasculature, and revs up the inflammatory response and the autoimmune response. And in their diagram, you see they kind of have an overlap and a progression from viral infection to immune response with the varying symptoms and diagnostic tests that we do, probably changing and developing and progressing over time as well. Next slide, please. So this is a diagram from a wonderful article written by Sean Jackson in Blood 2019 that's called Thromboinflammation. And he was trying to get his point across by saying that thromboinflammation is a really important pathologic process in a diverse range of human diseases, a lot of which have microvascular dysfunction. And so for things like sepsis and reperfusion injury and those sorts of things that you see toward the center of the diagram, they have widespread activation of coagulation throughout the microcirculation, as well as a very intense inflammatory response. Some of the other disorders that you see out at the periphery are more heavily weighed in one direction or the other, but overall that there is this interaction between clotting and inflammation. The picture on the bottom shows us that when you have tissue or organ injury through multiple diverse pathogenic mechanisms, you oftentimes will then get microvascular thromboinflammatory responses. You have an insult, it causes inflammation, endothelial dysfunction, and all the different cellular elements that are in the bloodstream can mediate microvascular destruction with occlusion then as a consequence of activation of the coagulation system and fibrin generation. So regardless of what the primary insult is to the tissues of the organs, the ultimate outcome of these disorders is heavily influenced by how much microvascular disruption, thrombotic and inflammatory responses occur. Next slide, please. So ordinarily, this is from Dr. Jackson's paper as well. Ordinarily, there is a very slick, non-sticky, anti-adhesive phenotype to the endothelium. I mean, junk isn't supposed to hang on to it. And it's maintained by the mechanisms you see here. We're not going to go into detail. Again, I think this is a fabulous paper. But there are pathways which interfere with platelet adhesion and stickiness, the first three. There are mechanisms that neutralize activated clotting processes, the antithrombin, thrombomodulin, and protein C that you see more toward the middle. And then lastly, there actually is something called tissue factor pathway inhibitor that's supposed to keep actual clotting from being triggered. So if your endothelium is disrupted, this mechanism to keep it anti-adhesive, all these mechanisms can be totally disrupted. Next slide. So to pictorially show you that it gets worse, can get worse, the non-sticky endothelial cells then get very sticky and become pro-inflammatory, pro-thrombotic when you have things that irritate or injure the endothelium, like reactive oxygen species, endotoxins, inflammatory cytokines. They lead to activation of all kinds of surface molecules and species that make platelets stick, that make white cells stick, that generate fibrin from all the different proteins in the clotting cascade. And then that also exaggerates and enhances elaboration of pro-inflammatory cytokines and other noxious specimens. It's made all the worse in the second panel you see by von Willebrand protein and other molecules hanging onto the platelets and making them additionally recruit friends and aggravate the white cell into making other bioactive substances from a different mechanism. So once you get going, you keep going. Next slide. So how would a hemostatic imbalance be identified if you had one? Well, you could in the lab and in person see evidence of endothelial inflammation and activation. So in the lab, we can identify lupus inhibitors. Patients make antibodies because of endothelial disruption. You see it in all kinds of infections and all kinds of inflammation. And I found it on ECMO after bypass, on assist devices. So it's any sort of endothelial disruption can produce these lupus inhibitors that you see in the lab. We also can find very abnormally high and then low factor VIII and von Willebrand protein families. Remember, I talked about those kind of grabbing platelets and making sticky things happen on the endothelial surface. And then we can see clinical vascular changes. These pictures are from a paper in Peds Derm that's in press out of Italy. Andini is the author. These are pictures of folks who have what they think is COVID Kawasaki, and they did a biopsy. And the arrow pointing at the biopsy shows thrombin in the middle of a small blood vessel, which is encircled by a bunch of lymphocytes. This has not been a consistent finding in the other derm literature that's been biopsy patients, but you know, I wonder where people are in the continuum when someone pulls the trigger on a biopsy. And then we also know that there's hemostatic imbalance when we pick up evidence of activated coagulation. Initially, when everything is all revved up, you've got high fibrinogen, high factor VIII, high von Willebrand disease, D-dimers. You're already making clot if you find D-dimers. And then at some point, the system might become overwhelmed with everything dropping and clinical bleeding as a consequence. And we will see clinical clotting abnormalities, both venous and arterial, deep venous thrombi, catheter-associated thrombi, pulmonary emboli, stroke, and arteritis, both large and small disease. Next slide, please. So, well, what is there to do about this imbalance? Well, we can modify the trigger, we can modify the blood vessels and the vascular endothelium, we can modify platelet function, we can modify coag function. And it all depends upon where you are in the course. Next slide, please. So this is from a paper in 2017 in Annals of Intensive Care, an author named Delabranche, I think it's French, looking at the continuum once the clotting cascade is activated, once you have inflammation starting and clotting beginning. And he calls this, instead of inflammatory disease, he calls this immunohemostasis. So it depends upon which side of the coin you're going to flip. But the point is here that as the insult occurs and progresses.
Marie, I'm very sorry to interrupt. I just wanted to give a brief time check. We're at 8:25 and I'm not sure. I'm looking at the slide deck.
I see ya. Yep, I'm rolling. So you can see that you can be very sticky and wind up being very bleedy at the end. Next slide. So what are we to do? Well, you've got immune modulators. You've got vascular stabilizers, which would be the holy grail. So maybe that's what MSCs do. We've got anticoagulation agents we can use. There are some that haven't worked. The recombinant activated protein C and tissue factor pathway inhibitor, that's their stock. Tanked because they didn't work. And then I think we need to be more thoughtful about antiplatelet agents, aspirin, COX-2 inhibitors, and maybe other nonsteroidals. So next slide. What do we do? Well, the guidance is discordant. The Boston algorithm's to the left. It includes nothing. One of the New York hospitals is in the middle. They use Lovenox and or low-dose aspirin. And over to the right is Montefiore's, where they do ask for a heme consult before starting antiplatelet agents, TEGs, and follow the anticoagulation protocols for patients less than 21 years of age. The bottom line to all of this, next slide, last slide, oops, is that the pessimist is never disappointed, and I think we have to be prepared for patients to deteriorate and be very vigilant for bad things happening. And because we don't understand the pathophysiology, the continuum of the clinical spectrum, or have a multimodal management strategy that works, we need to create what does not exist. That's it.
It's great. So we here in Detroit have seen a significant increase in the stroke rate, the cryptogenic stroke rate over the past 6 weeks in the 30 to 45-year-old age range, primarily in females, interestingly. So it's caught the eyes, at least, of our hematology adult colleagues in regards to all of this. And I don't know, and all of those patients are COVID positive. So, and they're all pretty much African American, so they don't know if ethnicity is playing a role in this as well.
So I'm gonna just end it with after seeing these cases in Detroit, and we have, as mentioned earlier, so much to learn about it. And again, this is all our prelim data, and we need more analysis and more patients to determine, with collaboration with other centers, to determine what would be the best treatment and biomarkers to differentiate between all the spectrum that we talked about.
Thanks so much.
Thank you.
I think I have a minute or two for some additional questions that have come in on the chat. There was a couple of questions about timing of Infliximab, and if you thought that's prevented a need for ECMO in some of the patients who were quite sick, and then timing of remdesivir. How did you sort of decide when to start that, and have you started it in the other patients who did not go on to ECMO?
So that's a really good question. Usually in typical Kawasaki, the strategy that's been used here, after 36 hours after they get the first dose of IVIG, if they remain febrile, they will give the second dose. But for this group that we've been seeing, we've been more aggressive, and patients who remained persistently febrile with persistent systemic inflammation, and after 24 hours, we're giving that the dose Infliximab. And so yes, definitely we've been more aggressive, and that also have been helpful to prevent patients for further decompensation. And with time, we're learning more about the disease. We had one patient that he was significantly also sick, and he was in severe cardiogenic shock with severe troponin leak and severe depressed function. And we were able to treat him medically with no mechanical support, and by aggressively giving him the IVIG, and he responded nicely. For compassionate use, we only used it for patients with cardiogenic shock who were on ECMO for these two patients. Also, we're gonna use it for intubated patients in our center in pediatric kids. Especially, it was approved, especially after the promising data that was shown by the NIH study by Dr. Fauci, that there is promising results. And it was approved to be used in pediatric patients, and we're using it. We're planning to use it in our intubated patients, and also who required mechanical support, who have evidence of positive PCR. So the patients who have positive PCR will be using it with critically ill condition.
And then we have a question about right ventricular enlargement being seen in some adult patients, and whether that may be related to pulmonary hypertension. Have you seen that finding in your patients, or other evidence of pulmonary hypertension?
No, we've seen again the new onset of TR, tricuspid regurgitation, with mildly increased side pressure, even when they have severe depressed function with dilated IVC. And the thought about it that the heart might having acute myocardial stunt from the systemic inflammation, and then that will recover and resolve 48 hours after treatment. So we haven't seen findings like in adults, and again, the number is still limited.
Yeah, so for the kids, we haven't seen that. Again, the young adults, again, females more than males, it appears, and again, these are small numbers, but we have seen a huge uptick in pulmonary emboli in this group of patients. So the Heart Hospital here at Detroit Medical Center is one of the tier 1, whatever, pulmonary embolists. They have these new devices that we use and stuff like that to get it cleaned out and everything else. And normally they would see in a month, they'd see around about anywhere from 3 to 4 acute pulmonary embolus cases where they would require a cath intervention, or at least a catheterization. And over the past 6 weeks, they basically seen 3 to 4 per week. So it's really dramatic. And the majority of them, I can't say they tested all of them, but the majority of them are COVID positive. Again, whether it's, and interestingly, other than the pulmonary embolus or the coming in with the pulmonary issues, they're asymptomatic. And I've not pursued it far enough yet with my adult colleagues as far as whether or if this, kind of it's part of the initial disease process that we're seeing. So, but it is interesting that we're seeing with regards to this entity.
I think we have time for a couple more questions. We had so many people join today that I'm sure they'll be happy to stick around, and just such great opportunity to learn from experts. Marie, someone wanted to hear a little bit more from you, just thinking about microthrombi in the circulation, especially in the myocardial circulation.
Yep. I actually was talking with one of my friends who's at Duke, who did some of his early research with Warren Zappel, who described nitric oxide, and one of their models was microcirculatory obstruction in the pulmonary tiny pulmonary arteries and perialveolar capillaries. I think that's a problem with the lung disease. I think we have to be very conscious of the fact that I think it's a massive inflammatory response, and I think all of the microcirculation is vulnerable I don't think the heart is excused from the pathology, and that's why I just think it's really important to not take away all the antiplatelet agents just because you're going on a heparin or a bivalirudin or something like that. I think we need to learn from the adults doing coronary arterial work and think about the folks that do the devices that are on heparin and antiplatelet agents in order to prevent strokes. And I bet we need a multimodal endothelial calming regimen, if you will, which will be beneficial to the heart, the lung, the brain, and all the other, capillary beds.
Great, thank you. We have a kind of real practical clinical presentation question. Is the COVID rash blanchable? Maybe for our Detroit colleagues who've been seeing quite a few more of these patients, what kind of rashes have you seen, and have they been blanchable?
We haven't seen this rash that I saw in the ICU. I'm sure there are many other patients that are seeing in the emergency department and on the floor. The one that presented on the ICU.
Oops, we lost your audio for a minute there.
Oh, can you hear me now?
Yes, yep.
So I'm saying the patient that I've seen in the ICU, they had macular papular rash, and they were not blanchable.
Great.
I'll tell you the rash I'm getting from this COVID virus if I haven't treated. That's a blanchable rash there. So,
maybe just two last questions. Do these patients meet inclusion criteria for the Kawasaki disease trial, or do they need to be excluded and not included in that trial?
I would not. So they're being excluded. So this is a recent entity, and so they're kind of just grasping that right now. But as it stands, they want to, as we figure out more about this COVID situation and everything else, as far as the manifestations of it all, they're being excluded. So if they come into the Kawasaki, if they're COVID positive, they're being excluded.
One of our
they may follow them up, whatever.
Yeah, one of our pediatric dermatologists just weighed in to say that COVID-19 can have many different types of rashes. If it's non-blanchable, that implies a vasculitis, so maybe our sort of COVID toes type presentation, but I certainly have seen other descriptions of blanchable. So I don't think we can use that as a discerning feature, probably.
Good point.
And food for thought from one of our infectious disease colleagues that diphtheria causes a post-infectious carditis. Any pathophysiologic parallels between the two? Not sure the last time any of us have seen diphtheria carditis.
Yeah. I think I missed that class. That's a great question, and it's a great assertion in regards to the involvement of the post-infectious process that the heart has manifestations for. But that's a good question, actually. I never thought of.
Well, thank you so much. This was just really timely, and I think that it sounds like you guys are doing an incredible job taking care of some really sick patients. I was heartened to hear that they seem to be responding really well to aggressive treatments, and was sort of struck by how quickly they seem to be getting better after really significant interventions. I hope we'll be able to continue to collaborate and work together, and certainly wish you all the best in the work that you're doing, and thank you very much for joining us this morning.
Thanks for having us. We appreciate it. This is great.
Thank you so much for having us.
Absolutely. Have a great day. Thanks, everyone.
Thank you.
Thanks.
Bye-bye.